wondering if you see, or have you seen, or is there any movement towards looking at adults who actually have had pandas for a long time, or PANS? Because my son was 18 or 19, and my niece was 30. So I was just wondering if there's any.
When they had their onset, they were 18
no, the
and 30?
onset for my niece who's 30 probably was 12, and my son was probably 16, but he wasn't diagnosed till 18 or 19. But just wondering that there's probably a lot of adults walking around now who probably have had it. So if you could comment on that.
So the answer, the main question is, for what do you do about adults who had this as children and either weren't recognized and treated appropriately and now sort of are more chronic mental illness, or even if they had their symptoms come on more recently. PANDAS was confined to children prepubertally, specifically because of work at Rockefeller University showing that 98% of the population makes antibodies against the conserved portion of the strep bacteria by the age of 12. Unfortunately, it looks like the 2% that don't make those antibodies and therefore are never strep resistant may well be the same ones that are vulnerable to the post-infectious sequelae. So it's possible to get it, and we knew from studies in World War II that rheumatic fever, rheumatic heart disease, can actually happen in young adults. So you could even be 18, 19, 20, 30, probably not older than that, and have the new onset of what would be called PANS if it was happening in children, but it should be thought of as an adult acute onset and go down the pathway that Dr. Frankovich and Alarcio talked about in terms of autoimmune encephalitis. That's where I'd go first. Now, I'm working with Dr. Miro Kovacevic to try and write up his case series. He's the only one that I know of who thinks so far out of the box that he's been willing to treat young adults treated with IVIG when they've had symptoms for 8-10 years. He swears that he has seen improvement in patients with even a single course of IVIG. I think it is something that that one we actually have to test, because we've all talked about using IVIG a lot. Since I'm the old timer here, I can tell you that we used IVIG before there was a test for hepatitis C, and we actually gave hepatitis C to one of our patients with Sydenham's chorea because there was a contaminated lot of GammaGuard. IVIG is as safe as we can make it, but it's made from 6,000 to 20,000 human donors, and anything that any one of those 20,000 people has could be in that IVIG. It's tested, it's as safe as we can make it, but when I think risk-benefit ratio of IVIG treatment, I remember those patients and say, is it going to be worth it in this child? And many, many, many times I say yes, but many times I say no. Did you want to just? Okay.
Why don't we try a new question, Ryan? Dr. Frankovich, we're all trying to raise awareness and raise money to help Stanford be able to take on more patients. Right now, Francine, we're at 5-6 months out before you can see any more. What type of funding do you need, and what's your plan so you can reach out and help more families? Because after the media is hit, I know you're getting, I think you had 106 calls yesterday. 106 calls yesterday. You're going to be bombarded, and we need to support Stanford, and so you can see more children. What do you need?
A sugar daddy. No. Yeah. She needs to be cloned.
We need more providers. Whatever donations we get, I think we're going to put towards research, because if we can show that we're bringing in money for research, Stanford will provide the resources for us to expand our clinic. So this way, the clinical side, your medical insurance will pay for the services, and the money can all go towards, developing new research methods and therapies.
Okay, I'll make it short. Where do you go when an 8-year-old boy, a 7-year-old boy, with an extreme sudden onset, all the criteria, I won't go through with them, but classic PANDAS, even the emergency doctor said it's classic PANDAS. treated with clavulin, responded right away. 8 days later, 0 symptoms on the 12th day. He's perfectly fine now, but he's still continuing to make it to 28 days. What's the next step after the 28 days that he prescribed? Do you wait? Do you take long-term prophylactic antibiotics? Do you do IVIG? What do you do?
He's completely fine at this point in time?
Completely fine with clavulin, 8th day improvement, 14th day complete 0 on 10 scale.
That is absolutely awesome. So in that case, I would not yet start prophylactic antibiotics.
Okay.
Because of just suppression. If you did decide that you wanted to try immunosuppression, antibiotic prophylaxis, it would definitely be with penicillin VK. We were talking about it last night, and Dr. Cooperstock didn't correct me, but he may choose to. I believe that every bug worth its salt except strep can overcome penicillin, and therefore you don't really change the flora. So Pen VK is the one that you have to take 7 o'clock in the morning, 7 o'clock at night, not compulsively, but religiously.
So
and
you
that's an important
recommend?
distinction.
So you
But it may
recommend
not even be
prophylactic?
necessary because there was a
Okay.
lovely study from the 1950s that showed that surveillance throat cultures done once a month and treatment when positive, much like Tanya Murphy's study, was very effective. Or even better, use the behavioral symptoms as your marker of a strep throat infection. And if the behavior exacerbates, get him in, get the throat culture, and
Okay.
rapid treatment, he's probably going to respond as well.
But do the parents have to worry about jumping up and down from scale, being PANDAS, being environmental, or if you're PANDAS, you stay
No.
PANDAS?
Pandas
Is
is
pandas.
pandas. It
Okay,
sometimes
perfect.
generalizes the response to the initial response to strep can generalize in the immune system, and they may become reactive to other things. But epidemiologic studies that we can extrapolate from showed that 1 in 7 adults who had a childhood history of OCD, it had been spontaneous remission after only a few months, and they never had any more problems.
Okay, great.
So you're going to talk to lots of people who are going to be extremely jealous, but that actually is a Picacchiero experience where they treated those kids with antibiotics relatively soon in the course of illness, and they never had any
We
trouble.
caught it
afterwards.
within a week, thanks to
Yeah,
her husband.
that's what we want to happen for every single child from now on. Diana's saying she has at least 40 reports of exactly that same kind of phenomenon. And you don't have to put them in a glass bubble, you just let them live their life.
I just want to make one comment, though. I mean, I think that's incredible that your child is able to recover so quickly. But don't be discouraged if it takes 2 to 3 months to recover, because we definitely see that even with the simple PANDAS cases, it can take some time to get back to baseline.
We are under the amazing care of Dr. Frankovich, and our question is, our daughter has PANS, and in the last 12 months, as part of her crazy symptoms, has had 36 cavities. And I'm wondering if anyone else in the room has had a ton of cavities with their kids, and if you all know what's going on with the cavities. We're like filling holes as fast as we can.
So the question is whether dental caries or cavities can be contributing to this process, and the answer is we don't know the answer. Dental caries are infectious. It's an infectious disease. The organisms that cause it are streptococci. They're not group A strep by any means. They're other strep. So they'd be on my list of possible ones to think about. And I can't even tell you whether the body makes antibodies to those streptococci when you just have tooth infection without it being more. It'd have to be pretty deep to get to the circulations. So answer is I don't know the answer.
I'd like to say something.
Who's come here from another country?
Just a second. I'd like to say something about that. I would consider the possibility of just a possibility of celiac in this particular situation, which can cause complete, or not complete, but aggressive demineralization of the teeth and erosion of the enamel coating of the teeth and predispose your child to that many cavities. In fact, that happened with Lance. So just think out of the box.
Anybody from like another country or something that's flown behind me? Okay.
Hi, so I'm from Montreal, Canada. We have neurologists there who recognize that something called PANDAS exists, but will not treat for it. What they said is he has an autoimmune disease triggered by strep. They won't call it PANDAS. What they did was nothing. They offered us a psychologist assessment. They offered us anti-anxiety medication. My son is 7, and it started in January. We found a pediatrician willing to put him on antibiotics, so he's been on antibiotics for 11 weeks now. Based on research that we just did on our own, we started reducing his level of antibiotics. He's on Augmentin, and he was on 12 milligrams a day, 1,000 a day, sorry. And now we've reduced it by about half, and his symptoms are all coming back again. We don't have, the pediatrician we're working with is working with us based on what we're providing to him as information, but he doesn't know about this disease. So we're kind of not sure what to do.
So I'll answer most quickly and just say that I have the luxury of having a team at the NIMH, and we're not going to go into all the history, but we actually spend probably 20% of our resources on consulting with those kind of physicians. So I know that Diana and the PANDAS Network are absolutely wonderful and huge, but I get paid to do nothing but do PANDAS. So I would be happy to talk to those doctors. And Dr. Alarcio and I were just saying, yay, if they're willing to call it post-streptococcal autoimmune encephalitis or whatever, but then to do nothing, that's not the right answer. So if they're willing to consider the possibility but just don't know how to treat it, we're happy to work with them. And you can get our address through them. But don't be offended if you get an answer back from my nurse practitioner. Her name is Priscilla D'Souza, most wonderful woman in the entire world. My 2 child psychiatrists are Rebecca Hammer and Paul Grant, and some of you have actually already talked with them. Anytime anybody but me is answering, it's still my voice, so it'll be fine.
Hi, JR, my wife Melissa, and our 4-year-old daughter was diagnosed in November of last year. And within a week or 2, she was on antibiotics. My wife actually is the one that found it online and told them what we thought, and we did molecular Cunningham panel test. Everything, knock on wood, most things went away. One of the things that stayed was OCD behaviors. So being here today, seeing all this is just crazy because we experienced it. Our daughter had a flare-up again 6 weeks ago, and it seems like this flare-up, let me back up. She was off the medication for about 4 days. We were testing it out probably about 3 months ago, and everything started coming back, so we put her right back on the antibiotics. About 6 weeks ago, she started with another flare-up that has been really bad, and we had to switch antibiotics several times. I guess the big question is she on antibiotics until puberty or after puberty? And number 2, did these flare-ups get progressively worse?
I'm going to pass it to Dr. Cooperstock in a minute. My answer is yes, they stay on prophylactic antibiotics. We actually observed the American Academy of Pediatrics Red Book protocol for prophylaxis for Sydenham chorea, which is antibiotic prophylaxis with the least, what's the word? The narrowest spectrum effective against strep, i.e. penicillin, until age 21. Now, you can't keep most of the teenagers on, so a much more practical approach has been 2 years of symptom-free. You could consider coming off of antibiotic prophylaxis. And the whole, you saw from Dr. Alarcio's and Dr. Frankovich's slides, the whole point is the immune system has been activated and you really need to get back to a tolerance. I'm going to pass it to Mike because I do want him to respond more as the infectious disease specialist, whether or not that's warranted. And then Dr. Frankovich needs to address the question of whether you actually moved past the point of antibiotics as your main thrust of treatment.
I agree with what she said. She's a lot smarter than she sometimes thinks she is. The only thing I would add is that the alternative, as with rheumatic fever, is you can use once monthly injectable forms of penicillin that would work as well.
So I just wanted to clarify that question before I answer. Was the child diagnosed with PANDAS or PANS or?
She was diagnosed with PANDAS.
Okay.
And we're afraid that for her, the flare-ups could continue to get worse.
Yeah. And the flare-ups are getting worse. Oh, they're not. Oh, you're worried that they're going to get worse.
They're different. The
Oh.
OCD is getting worse.
So does she return to baseline after she returns to baseline? Okay, well, that's great.
And everything goes
Baseline
away?
with OCD.
Oh, then that's not
Still
baseline.
some OCD there.
Okay.
But it's not, I mean, we're very lucky. She's very lucky. It's not,
Yeah.
she's able to sleep through the night now with melatonin. You know, she's obsessed with time.
Yeah. I mean, so what we're struggling with up here is like, is it baseline? Is it not baseline? And this is something we struggle with in our clinic. I mean, do we get kids perfect? I mean, some kids we can't get perfect with just the antibiotic approach. Yeah. And we're struggling with what to do with those kids because, you know, if you're, you know, Tessa Gallo, you're not functional and you can warrant doing very aggressive immune suppression and try to get them back to a baseline. But if you're not so severe, do you really take the risks of steroids that cause eye problems and bone demineralization and you know, skin changes? I mean, there's a lot of, growth retardation. I mean, there's a lot of complications with immune suppression. So, you know, so it is something that, you know, we all struggle with as providers, you know.
So we're at the point, actually, this is the point at which we get most of our kids after they've been in our active IVIG trial with high-dose antibiotics to start and then moving to prophylactic antibiotics. At that point, every single one of them, we work with either their primary care provider or get them into a psychiatrist who will use judicious anti-obsessional medications and, more importantly, cognitive behavior therapy. And I had mentioned to somebody that I just met with one of our young women who was in the original treatment trial. She's 28 now and was a journalism major at Columbia. She said that her CBT training for OCD was the best thing she ever did in her entire life because she uses it for everything. If she's nervous about a talk at school, she uses it for anything else. So exposure with response prevention plus medications has been shown to cure 70% of children with obsessive compulsive disorder, and it gets them to, her baseline should be 0 symptoms, because even if the OCD is mild, I promise you it's painful.
Right off the bat with the cognitive behavioral therapy, is there a certain age in which you recommend that they start it?
Cognitive behavior therapy can be started as young as the child is rational and able to participate. And there are some lovely sort of self-manuals. One is done by the American Psychological Association, actually. There's another one, John March and Karen Mull published a book called How I Drove OCD Off My Land. And it's really very simple. 16 sessions. Think about how many times long this has taken. 16 sessions, so 16 weeks. In 4 months, your child can learn everything they need to know to fight it off in the future.